It's just not going to work there. I'll tell you what. There we go. I forgot what to get my jacket buttoned. But you can't do that if you got a big old thing right here.
All right, good morning, everyone. My name is Herb Lynn. I'm with the West Virginia University Injury Control Research Center, and welcome to today's Public Dialogues presentation. I have the distinct privilege of both welcoming our guest presenter, Dr. Robert Pack, to WVU, and also introducing him on behalf of our center director, Dr. Rob Bossert, who couldn't be here physically, but I think he's out there virtually. So, Dr. Pack is a professor of community and behavioral health and also the associate dean for academic affairs in the College of Public Health at East Tennessee State University. I'm sorry, there we go. And he's also director of the new ETSU Center for Prescription Drug Abuse Prevention and Treatment. That center grew out of a university and community collaborative that was started in 2012 by faculty members at ETSU, including Dr. Pack, and several community partners. That working group is called the ETSU Prescription Drug Abuse and Misuse Working Group. At least 5 funded projects and dozens of other academic products have grown out of that working group. Dr. Pack is currently the principal investigator of the NIH NIDA funded Diversity Promoting Institutions Drug Abuse Research Program at ETSU. And the research component of that is a 5-year set of 3 studies titled Interprofessional Communication to Prevent Prescription Drug Abuse and Misuse. Dr. Pack is trained as a behavioral scientist and health educator and is experienced in designing, running, and disseminating theory-based intervention studies. In 2014, he was trained at the NIH-funded Training Institute for Dissemination and Implementation Research, training that informs the perspective of the center that I just mentioned. Today, Dr. Pack will be presenting to us Prescription Drug Abuse, a Decade into the Epidemic, Lessons Learned in Tennessee. And we've been looking forward to this presentation for some time. So join me in welcoming Dr. Pack to WVU.
Thank you very much. Is the mic picking me up okay, and can you hear me okay in the back? All right, fantastic. It is an absolute delight to be back here at WVU. I spent the first 9 years of my career here, from assistant to associate professor, and then left in 2008. And along the way, made many fantastic friends and had just a wonderful experience here. It was a absolute delight to be here. The first time that I began engaging in this topic of prescription drug abuse as an academic topic and one as a public health problem was around 2005. And that was about the first talk I gave on this topic. And it's around the time that a close personal friend had a massive problem with this. He subsequently lost his life secondary to this, and it was that and just the epidemiology and just the sheer catastrophic nature of this in our culture and our society right now has been just keep me engaged in this as something that's important and something that we need to be paying attention to and bringing some good public health programs to in order to prevent it. So I'm going to share some of our progress in Tennessee. I'm going to share some of our data and tell you how we've been conceptualizing things. And hopefully we'll be able to establish some partnerships with both WVU, maybe you, this particular issue, okay? So that's the long-range goal. Well, and the long-range goal is that we fix this. That's the intermediate goal, let's put it that way. So I always start out to talk about prescription drug abuse, talking about the fact that we have a ridiculous amount of opioids, okay, ridiculous. And most people don't know that we consume twice as many opioids per capita as the next closest nation. In 2014, we were the second state in Tennessee in terms of consumption, and Alabama was actually the first. We were only second by 1/10 of a percentage point, according to the CDC at the time. East Tennessee, unfortunately, is number one in the number 2 state. So this is Tennessee. It's 500 miles corner to corner. It's a rhombus. We are actually in Washington County. See the pink over to the right? We're right in Washington County toward the border, okay? And people often think of Knoxville as being, where UT is. That's an Orange County. It's right there. What's that laser pointer? Is there a laser pointer around? Where? I see one. But anyway, so that the geography of Tennessee is such that pretty much everything from Knoxville over, and I guess down to around Chattanooga, that's pretty much Central Appalachia as well. That looks about like here, except the mountains are a little taller. It's a lot more farming than it is mining, but it's still Central Appalachia. So what this slide is showing you with respect to opioid consumption is this is data that our state controlled substances monitoring database has reported, where the dispensed opioids in the state are normalized to milligrams morphine equivalent. Okay, it's a 1 standardization. So that's basically the amount of dispensed prescribed MMEs basically on top. And then what we did was we asked them to break out buprenorphine because buprenorphine would also be captured in the top statistic if you combine them both together. And buprenorphine is used to treat opioid use disorder. Okay, so this has given us a better idea of actually what's happening between both prescribed opiates, consumed opiates, and used presently. Now we don't have methadone stats because methadone doesn't have to report to the CSMD like these other substances have to be reported. So that's what's happening in Tennessee. You can see that the problem is really consumption in the eastern part of the state. This is basically cumulatively what's been happening in 2012, 13, 14 with respect to the amounts of MMEs and buprenorphine MMEs. So we actually had about 8.1 billion MMEs prescribed and dispensed in Tennessee in 2012. That's gradually been declining thanks to, we believe, our controlled substance monitoring database efforts and some others. We've also been increasing in terms of buprenorphine. So all of this data that I'm sharing with you here it comes from our State Epidemiology Outcomes Working Group, which is a mandated group grant that the state got from SAMHSA. Is there an SEOW in West Virginia? There used to be years ago. There used to be an SEOW out of Marshall's Prevention Resource Center. Don't know if it's still running. Okay, no one knows. All right. So anyway, the SEOW in Tennessee put together what is basically the heroin indicators. And what we did was we collected a lot of different data and from the Tennessee Bureau of Investigation, Tennessee Department of Health, the Controlled Substances Monitoring Database, and pretty much Tennessee Department of Mental Health and Substance Abuse Services, and we pushed all of those data sources together to identify what's really going on in the state. And what we uncovered really by pushing it all together was that the problem is even worse than we thought. The crime stats are up, the overdose death rate is up. Dispensing, thankfully, is going down, and I'll share a little bit more about that in a few minutes. But basically, these are the opioid overdoses Methadone's flat. Heroin is increasing. I have a detailed slide on heroin, but I took it out. What's happening in the last couple of years, but we'll just move on for now. This is actually from 2002 to 2014. In 2002, there were 23 contiguous counties in the nation that had an overdose death rate of higher than 20 per 100,000. We weren't paying enough attention to pick this up then. That this wasn't something that was on the radar, okay? Now, we've got these fancy tools from the CDC where we can go back and look, but that number, these 23 counties, were the only place, this is the only place in the country that had an overdose death rate that had counties that were similar in clusters. There was a few out here, but those really aren't, I mean, that's actually one, that big one over on the left is actually one county. But they weren't contiguous, and that is part of what points to this as the epicenter of the problem, all right? Now, of course, we have the problem across the entire U.S. And it is tragic, and it is gathering a lot of attention, finally, I must say, at this point. In 2014, our overdose death rates in Northeast Tennessee were basically, this is basically our area for the catchment area for the center. And we're right here in Washington County, but that's what our particular detail area looks like. Now, there's a lot of news, there's a number of news stories on a forthcoming publication in the Journal of AIDS, where some folks at the CDC put together a map, put together a list actually of the 220 counties, Judith, is that right? 220 counties where there's most likely to be another outbreak like we saw last year in Scott County, Indiana, of HIV. Is anybody familiar with what happened in Scott County, Indiana last year? We saw cumulatively, I think, around 200 cases of HIV where they expected to see only 5. And it was all secondary to needle exchange. And so this, or I say all, it was mostly probably secondary to needle exchange. So the folks from the CDC put together a map of where they think that is most likely to happen. Appalachia. Well, I mean, you can see it. It's obvious. Hey, thanks, Crystal. Oh, excellent. Appreciate that. This is that's fantastic. Much more comfortable. All right, so the state with the greatest number is probably West Virginia as a percentage. Second is probably Kentucky, and we have a huge problem in East Tennessee as well. But we're going to have to start thinking about this problem from an infectious disease perspective. And I think that Judith, I think your work is going to be absolutely essential, and what you bring here from Ohio is going to be absolutely essential to how WVU responds to this problem here in the state. These are a compilation of our heroin indicators all in one slide, and basically just showing you what's going on in the state from multiple different perspectives. And I encourage you guys to get engaged with whoever at the state can help you do this, because it helps people understand what the scale of the problem is, right? This was actually requested by the governor, and then together to do it, but it's become pretty much one seriously, and one of the governors that's becoming an expert on this topic. So anyway, you can see what's happening here with respect to heroin, with respect to drug seizures, treatment admissions, crimes, arrests, and poisonings. They're all going up. Unfortunately, this number right here is absolutely tragic. Another really negative outcome from this whole epidemic is the number of babies that are born dependent on narcotics. And this is neonatal abstinence syndrome. And babies aren't being tapered. I'm sorry, the moms aren't being tapered properly. There's not an evidence-based orientation to this, unfortunately, in parts of our state. And so we're really seeing a number of babies that are being born dependent on opiates. These are babies that are inconsolable. Do you guys have a problem here? You can see it at the NICU, right? And so there's a real problem with this in East Tennessee. The babies are inconsolable. They're very, very difficult to attend to in the NICU. Their length of stay is much, much longer. At this point, there are a number of potential activities around this. We're beginning a registry, a volunteer registry. Moms, babies engaged in that, a better service with these babies, so that when they go into school, that they can be, that we can help them be prepared. At any given time in our NICU, now it is the NICU and it is a teaching hospital, so it's going to be more there, but at any given time we might have 60% of the babies with NAS. 60. Yeah. Now, again, it is the teaching hospital NICU for that region. In our state, we think that about 5% have enough of a problem that they need early intervention or they need treatment. These are numbers from the State Department of Health, and then the rest of the folks probably could be helped by some prevention. So we've been trying to think about how to conceptualize this for a while, and one of my colleagues said, well, what about placing everything on the continuum of the disease and then kind of seeing what you have then? So that's what we did. We laid out the continuum, right? This is non-use. This is death. Okay, this is the logical outcome of overuse. And sort of on the left side of this, there's primary prevention, right? And then secondary prevention, tertiary prevention. This is a new name for it. This is naloxone, right? Quaternary prevention. That's bringing somebody back from an overdose, and that's not desirable. But what we have discovered is with a lot of analysis of the literature and other programs that are out there, particularly looking at meta-analyses, systematic reviews, and randomized control trials, is we can actually find strong evidence for each of these blue rectangles, okay? And those blue rectangles really work at different points along the continuum. So dissemination and implementation of effective primary prevention programs is really most effective right over here, right? You're not going to really spend your money on folks for prevention programs if you're, already looking at a dependent group. So different strategies. There are 300 plus programs that are on the National Registry of Evidence-Based Programs and Practices. 300, right? The NREP, if you go to the NREP website, you can find, I think it's 350 now. And what you can do at NREP is you can look and see what the different interventions do, what they're effective for, and you can get contact information basically in lay person's language. It's a fantastic website. But my point is, there's so many primary prevention programs that work. Let's stop trying to reinvent new ones. Please. I mean, if I ever hear of, the local Rotary Club that wants to do a new intervention, it drives me insane. I'm like, well, hold on a second. Let's just look at and see what you need. Let's go and get the right good stuff. There are people that design these programs over their entire careers, and they're excellent. Let's use the good stuff, right? And this is also true. We also know, for example, that prescription monitoring programs and diversion control really works. We decreased the volume of high prescribers and the doctor shoppers in Tennessee by about 50% by monitoring the controlled substances monitoring database. This is, our state Department of Health Commissioner, his name is John Dreisner. And John was he was a local physician in Southwest Virginia before he became the commissioner in Tennessee. And John is a true expert on prescription drug abuse, and he got a lot of stuff pushed forward quickly. He got NAS, neonatal abstinence syndrome, to be reported. That's key. So now we have good data on NAS. We know what's happening. He got the state to mandate use for the CSMD within a week. You have to upload all your information about prescribing and dispensing. Pharmacists have to check it. So we know that with good diversion control, you can have an impact. But really, that really works for people who are already dependent. If you're a drug seeker, if you're going to multiple physicians or pharmacies and doctor shopping, very likely that you have a pretty significant problem, at least at the dependence level, if not already over into the addiction space. We know, for example, that there are fantastic tools for both traditional and medication-assisted treatment, traditional abstinence-based as well as medication-assisted treatment, if it's done right, if it's done well, like it has been practiced here, I know. So you can there are really excellent tools for MAT, including Suboxone, methadone, Rexone. So you can, Vivitrol, you can actually really do a lot with medication-assisted treatment. But that's not to throw out the traditional treatment and traditional abstinence-based treatments, which can be very, very effective for the right people. People need to be mapped onto what's going to be most effective for them. But that really is only working in this space along the continuum, right? Then there's overdose reversal with naloxone. Thousands of lives have been saved with naloxone, and I agree with the promotion of its use, but I absolutely hate that we're there. I mean, that, to me, is an abject failure of public health that we are at this point, where we are dealing with naloxone as our best solution. Come on. Now, we promote it. We train people, and our team does this because we believe that it's absolutely necessary, but good night. I've even got some in my office. We had a kid that overdosed in our building this past semester. Evidence-based drug courts, we all know the story about, well, I presume that you all know the story about evidence-based drug courts. It's basically where people have to check in after going to treat. They have some sentence or crime for a drug crime, then they have to go to treatment. It's way better for them. We need to do better training about the tools for bringing moms off of the prescribed opiates, be they Suboxone or other opiates for pain, although you really, got to be careful as a physician to be prescribing someone that is either pregnant or of childbearing age, certain long-acting opiates. Then there's screening, brief intervention, referral treatment, which really works in this space, as well as this one, which is huge, health professions training and continuing education. Medical schools, nursing schools have done a terrible job with this, with both training clinicians, appropriate pain management, as well as opioid prescribing. So this is something that really has to be turned up, and there's some excellent new tools for prescribing guidelines. So the perspective that we bring is in our centers, everybody is mapped onto one or more of those boxes, and they monitor the use in our region. Okay, so that's the idea behind the centers, that everybody gets engaged with different areas on the continuum. I'll talk about the center in a few minutes. We also treat this like a supply and demand problem. Now, I need to give proper attribution to Commissioner Dreisner, who first started talking about this. So you got the prescription drug supply, and then you got demand. These are people who are already dependent, right? And then these are people who potentially could be dependent. And all of that basically, anytime you expand the length of one of these lines, you expand the prevalence inside the diagrams, basically what this is. And so through aggregate efforts, if we basically turn down the demand and turn down the potential demand with good treatment and good prevention, and also control the supply through dispensing appropriately and prescribing appropriately, then we can begin to push down on this problem. It's a little, it's not as perhaps complex as the whole problem actually is. But one thing that this slide does is it points out the fact that there are enormous dollars being made right here on the supply side. The prescription drug supply side, not only from the drug companies, but the Suboxone shops, there's a lot of money being made propagating, in some cases, bad practices. And so we need to focus on really good prescribing practices and focus on the supply side, as well as all of our other classic public health approaches. So a couple things to be cautious of. We started looking at the policy studies and how all this works. Every state is unique when you begin talking about implementing policies in those states. And so I know that's nothing new. It's not any kind of new finding, but you can't take a policy that works in Texas necessarily and apply it in Tennessee. You really need to begin, kind of figuring out what are the real issues in the context of those states. And there's often a pretty good lag period before impact. And that was particularly true. We really, the public health informatics aren't good enough to see what's happening today. I wish they were. Right? We can actually look and see what's happening last year. And it's pretty long lag time. But a couple things that were done, specifically with respect to pill mills, I want to point out. They did some pretty strong pill mill regulations in Texas and began to reduce volume prescribers. Same was true in Florida. Florida was, at one point, Florida was the Wild West. They had gone nuts in Florida. There were people opening up pain clinics and prescribing was through the roof. The 25 highest volume prescribing counties prescribing practices in the country were all in Broward County. It was something crazy. So, but they began to crack down on that, and that really helped us out because the number of people that were going to Florida and coming back with thousands of pills and selling them on the street, that stopped. However, it also pushed out some of those pill mills back up through Georgia, South Carolina, and into Tennessee. So we then had to start looking at doing a pill mill law, which we did last year. So but we couldn't take Florida's. We had to look and see what would work for us. But often what's happening with the pill mill, well, with all kinds of different legislation is it's being written or it's being drafted by people who aren't necessarily all the way read up on the literature or necessarily what happened somewhere else. So that's just a caution. I encourage you to get engaged with. I know you can't lobby for different things because you're a state institution, but I encourage you to get engaged with your state lawmakers so that they know who you are and what you have going on, such that they will seek your opinion about what they're going to do. That is, I think it's part of our obligation as public health professionals. But anyway, Florida had a pretty good impact. This is our state plan. Now, I don't expect you to read it, but I'm going to go through a couple things here that I think will be helpful. So this was a one-pager that was the goal was to get everything that was being pushed forward on the one page so that it could be consumed. Okay. And it's a little noisy, it's a little busy, but it kind of gives me a little bit of hope because these are all connected to evidence-based strategies. This is not just kind of guessing, right? This is not just like your best guess about what's going to happen. This is all really kind of buying into this concept of dissemination and implementation science. Improving primary prevention, right? And then multiple different activities. Right? Improving monitoring and surveillance, right? Improving regulation and enforcement, which is another piece. Eliminating pill mills, right? Increasing utilization of treatment. And this is true for both, well, hospital beds for this problem are actually really, really rare. At this point in our setting, they're just not around. We're trying to expand access presently, and that's a real problem. But the federal government is pushing the use of Suboxone, buprenorphine products. We'll talk about that a little bit more in a few minutes. And then the last one here is increasing access to appropriate pain management. And appropriate pain management, you know, with specialty certification requirements and things of that nature. Expanding the availability and use of naloxone. We've had the Project Lazarus folks over several times, and they've been consulting with Tennessee. I know they've been consulting here as well. Fred Brazen's been up here. He said to say hello. I saw him last week. There's a lot that you can do with this. Anyway, our point in Tennessee is that if we can promote anything, it would be multifactorial, because when you press on one side of the balloon, something multifactorial approach grounded in evidence-based solutions that are going to have good data, and then that data needs to be reported out so that then you can monitor it and pay attention to what's actually happening. That's absolutely essential. And what I would love, our vision is to have a Central Appalachian data repository where we can track what's happening at the county or FIPS level, right, and really see where even more attention needs to be paid to certain aspects of this problem. And push forward against all of these different points along the continuum, push forward against all of them at once so that we can begin to have an impact. It's not going to be enough to just focus on MAT. It's not going to be enough to just focus on naloxone, and it's definitely not going to be enough to just focus on prevention at this point. So this is a state approach in one slide. So at the bottom it says, and these are sort of undergirding principles here all across all 5 areas, but it says expand and strengthen key partnerships, collaborative infrastructure, secure, realign resources, infrastructure, and implement comprehensive approaches, and then use data evaluation and research to inform interventions and continue improvement. So the Department of Health is bought into this concept, and they're strong partners, and I think they're leading in terms of the state response to this problem at this point. So what are we seeing? Well, we're seeing a decrease in overall prescribed MME. Okay. Mandated use of the PDAM, which I mentioned. Overall, the MME volume is down, but overdose deaths continue to rise. And unfortunately, there's a non-prescribed product, the heroin product, that is also being cut with fentanyl, as everyone's probably heard it in here, which is a very, very strong, unfortunately, extremely strong product that is creating a lot of overdoses. And that is, what county was it, Judith, that you were mentioning earlier that had the huge number of fentanyl overdoses in Ohio? Hamilton? Was it Hamilton County, Judith? That had I think it was. Anyway, they're seeing this in Ohio, all over the Mid-Atlantic. Suboxone's increasing, and Suboxone done well is welcome. Although I got to say, Suboxone, unfortunately, in our neck of the woods, is beginning to get the people are beginning to take the view that they're just replacing the pill mills, and overdose death from Suboxone is extremely unlikely. So from a harm reduction perspective, it's much preferred. But there's a whole bunch of diverted Suboxone on the streets because of people basically being prescribed enough that they can actually sell part of it in order to pay for their Suboxone business. And there's a lot of cash-only businesses et cetera. So we know that stronger regulations are linked to decreased supply in some other states, and then lower supply is typically correlated with a decrease in overdose deaths. At least it was in Florida. I'll tell you a little bit about our grassroots efforts that really kind of organized into the center. We started in 2012 basically with a handful of people, 4 or 5 people, kind of staring at the ceiling saying, who else needs to be here and what else do we need to do? We kind of met late in the afternoon, no other pressures, and these were scientists and you know, engaged community people, and sort of said, who else needs to be here and what do we need to do? And out of that has grown a lot of stuff. We meet monthly. At this point, 40 people on the email list, and 20 to 40 show up every month. We alternate meetings between on campus and off campus. And Sarah, since you left, we've actually started meeting off campus with some places, and those tend to be better attended, actually, because people are always concerned about parking on campus. So anyway, so we'll alternate back and forth, and the meetings go like this. The agenda sent out on Monday, Tuesday meeting. No one ever really promised anything. Most of the meetings, 45 to 50 minutes. And it's what they have this going on this new, right? So if we've got 20 or 40 people in the room and you're going around the room and everybody's saying kind of what they do, we encourage that sort of lengthy introduction because that prompts someone else to say, well, wait a second, have you thought about this? And then making those connections, it becomes this really fertile ground for beginning to connect on new ideas. And it's really rich because you have the researchers who can pose their questions. You have people from the community who might have a research question too, but often they're running a really cool program. It's been very, very interesting, and it's really helped us think through how we need to approach this. These are kind of where they're all from. So we have some from Allied Health and coalitions, and you can probably, actually you might be able to read that in the back, but they're from all over the region. In fact, one of the most fruitful, these people are very powerful, the economic development people. One of the really fruitful collaborations that has come out of this has been with our county mayor, who through engaging with a working group has allowed his staff to become trained in an evidence-based program for employee assistance, and they become a drug-free workplace through engagement with this program. So been really pleased with that connection. Anyway, all kinds of folks from all different walks of life. And one of our coalition directors, keeping her connected, right, and helping her get unstuck from different things. And it's been a very, very fruitful collaboration for us as well. We got a celebrity in our group. Stephen Lloyd is he's a physician who's in recovery. And Steve gets invited to the White House all the time, and Steve is on cover USA Today, and Steve's been interviewed on Today, the Today Show, et cetera, et cetera, et cetera. So Steve actually has been he's one of the very best speakers about this topic. He's absolutely passionate, and he gets people fired up to do something about it. But Steve is one of the folks that I've come to know and love through doing this. His energy and enthusiasm is just absolutely infectious. The working group, I look at it like this. The working group is just this fertile ground for new projects. And sort of the green ones are funded, and the red one recently we learned was not going to be funded. We got other ones under review, et cetera, et cetera. So the idea is that just out of that just kind of bubbles all these new kind of topics and things. And so what we did was we got the vision for creation of the center after we got a large NIDA grant, 5-year NIDA grant that hopefully we're going to be able to keep going. This is our NIDA DIDARP team, and I wanted to put this picture in because it had a picture of Sarah Warfield in it. Sarah is now a doc student here. You guys recruited her from us, but she's right there in the front next on my left. But this is our primary research team. It's not the larger working group. That's just who's working on our grant right now, or I guess then. Bunch of different products have come out of this. I think it's more than 500 projects at this point. That's less important than the actual impact. The impact is we were able to get a regional coalition, another county coalition funded, a whole lot of different primary prevention programs, some naloxone distributions, all kinds of public health connected activities in the community. This is Angie Hageman, sort of my right-hand person. She's absolutely amazing. She's the director for our research team and does an amazing job on that. We're doing some overdose outreach work. So this is the center. So we organized into the Center for Prescription Drug Abuse Prevention and Treatment, and we have an admin core, patient care core, research and evaluation core, and education and outreach core. The idea behind this was that if we were going to be able to sustain this over time, we needed to have a funding model that basically was diverse. We couldn't just do this on grants. We couldn't just do this on state dollars. So we needed a more diverse funding model. And so what we did was we went to our health system, and our largest health system is Mountain States Health Alliance. I forgot the number of hospitals, but they're also merging with the second largest health system. And it's a good time for them to be doing this because they're going to find some savings in that merger. And so they said, okay, we'll partner with you, and we'll be the clinical care provider, and all of the revenues from our clinical care operation for medication-assisted treatment and methadone, all of the revenues from that will go back into the center. We'll do a for-profit model. So you have a clinical care piece, but you'll also be able to put the revenues after costs back into better education, outreach, and so on. So it'll be more of a coordinated approach. And so we're going to have research funding as well as clinical funding as well as state funding, and hopefully that diverse funding base will allow us to keep something sustainable, or keep this organized and sustainable over time. But the idea is that with each of these, every single individual, staff, faculty, student, whoever, they'll be mapped onto attending to what's happening with different interventions in their scope of responsibility, okay? So every single person will be mapped onto these blue rectangles, and then they'll be reporting back out to the community about what's happening. It's fairly exciting times. I'll say this patient care piece is a whole new world for me. I'm not a clinician, and I've found myself being a spokesperson for methadone, which, I mean, I'm a primary prevention guy, but in reality, we have to have methadone. We actually don't have any methadone in Northeast Tennessee. Folks have to drive into North Carolina or for methadone, and those are both for-profit clinics. And so what we're trying to do is a not-for-profit methadone operation. We'll also OTP, opioid treatment program, as in the back, and that's the goal right now. Our center was approved by the Tennessee Board of Regents in April. The partnership with Mountain States was formed in May, and presently we're engaged in a community discussion about where to place the methadone clinic. Anyone want it? Everybody care? So it turns out that methadone, there's not an increase in crime around methadone clinics. In fact, we brought up to a community meeting last Thursday night. We brought up the sheriff, not the sheriff, he's a police chief from Knoxville, who basically said, look, what these guys are proposing, you want. This is going to have a lot of parameters around it. And he said, we don't have any crime from our methadone clinics. Where we have crime is outside Suboxone clinics that are unregulated and also outside pill mills. And so he was a pretty strong advocate for us last Thursday night, where we had this community meeting in the location where we're proposing to site the methadone clinic, and over 200 residents showed up. That was a pretty tense meeting, I can tell you. We had some supporters there, but for the most part, in their backyard. It's, you know, it's pretty interesting. Meanwhile, there's almost 100 folks who have X numbers to prescribe Suboxone in our region, and several of them have opened up their doors as, you know, Suboxone shops that are like just running people through them all the time, right? Which we'll discuss at some other point, perhaps. Suboxone done with counseling, with good follow-up, Suboxone done correctly is the right thing to do. Anyway, so that's our center. We're focused on the problem. Our key lessons learned, okay? And I'll stop here after this for questions. Key lessons that we've learned is that the problem is much bigger than we anticipated, period. And one of the other things that is infuriating about this is opioid use disorder in particular just has deep hooks, and it is a really challenging thing to get over. And I mean, so much so that that there are predatory groups that are looking at ways to further make money off of this, and it drives me insane. I saw one. There's one prospectus that somebody showed me for a hedge fund or something that owned a lot of methadone clinics, talking about strong industry tailwinds. And strong industry tailwinds means that you have developed a very cynical view of this problem. That means that you've developed almost like a mercenary level view of this problem, and I'm really concerned about that. Efforts to address the problem of opioid use disorder are fragmented, and I think everybody believes that their one thing is the one thing that's going to fix it. I think that the CSMD folks believe that. I think that there's different. It's not. It's got to be a holistic approach pushed back against this problem at once for a sustained period of time. Policy is going to be key. Policy done well is absolutely essential. We need to help folks find out what the best policies are and how to tweak them for their particular situation, and write them so that they'll pass. Politicians are highly concerned about the workforce and the ability of the workforce to pass drug tests. This is a real problem for us in Northeast Tennessee, and this is the point at which we got our heavyweight politicians involved. They're strong supporters at this point. We got to do something about helping people their jobs, and you have to create a workforce ready for industry to come in. You can't have a workforce that is where you're saying, hey, we can, you know, bring in this new manufacturing facility where people are going to be running machines, but you have to engage the community, and you got to show up. We've had to cancel one meeting for the working group, and that's in, you know, 4 years plus. You got to show up. That one, unfortunately, was a result of a bunch of embargoed information, and we couldn't release it, and so it was. I still feel bad about it, but the reality is, if you engage with the community and in a way that is just open to hearing what they want to have going on, they've got great ideas, and they're on the ground fighting every single day. So if you can engage with the community and show up, you're going to learn some really cool stuff to do, and it's going to help inform all of your practices going forward. And this last thing this last thing is particularly troubling, and I don't know how to get around it. But stigma about addiction is still a major issue. And when I say stigma, I mean like this whole "not in my backyard" thing is rooted in stigma. And you know, what's ironic is, and this is particularly ironic, there was actually a Suboxone clinic in the very building that we're talking clinic in, the Suboxone clinic for several years, and no one even knew about it because certificate of need for Suboxone, go through this whole process, right? But they're because we have to do that for methadone. You know, the community's up in arms about it, but it's all about. I mean, if you can reduce stigma, what it absolutely kills me that the folks in the room don't recognize that this is not about somebody else. It's about their husband, wife, mom, dad, brother, sister, son, or daughter. And unfortunately, in our region, this is it's a huge problem that unfortunately is going to affect generations to come. So those are our key lessons learned right now. I'm sure we can come up with some more. I would be glad to take any questions at this point. Yeah, Sarah? Mm-hmm.
Okay. And I think your community engagement will help to uncover that.
Mm-hmm.
There is one subsection of the population that is taking opioids in order to get themselves to work every day because they have very real injuries that aren't being treated.
Mm-hmm.
So these are people like short order cooks, minimum wage jobs, miners,
Mm-hmm.
servers, HVAC people, and they don't get time off for illness. They
That's
don't
right.
have the health insurance to pay for the treatment they need for their slip discs and all of these things. And so you can show a reduction in opioids
Mm-hmm.
and still be really hurting a subsection of the population.
Yep.
And so it seems to me that the more we get into this, and I think that your community engagement is spot on with
Mm-hmm.
this, we'll see that we have to figure out what to do for people who actually just need treatment for injuries.
Yep.
And they can get off the drugs.
Yep.
Then there's another thing about the physiology of opioids.
Mm-hmm.
And the thing is, post-surgically,
Mm-hmm.
what you want to do, the key issue is to stay ahead of the pain.
Mm-hmm.
And your body does not become addicted when it's in that kind of pain.
Right.
So I'd hate to see them start not using opioids post-surgically, but where the prevention programs come in is seeing when it's time for them to titrate off.
Right.
Do you know what I'm saying? And
Yep.
not to allow it to go on. So, you know, just a thought.
It's a tremendous point and one that I'm concerned about as well. I see this all the time, and when we're talking about this, it's often the case that we don't take the time to also explain that the appropriate prescribing for pain is absolutely essential. These are some amazing drugs that are really helpful, and so we have to be careful not to throw the baby out with the bathwater, as it were. There's that is the downside to all of this restriction on the supply side, and it's going to be a very troubling period at least for some period of time until we get it worked out. I think the abuse deterrent drugs that are hopefully forthcoming will be very helpful in that regard. We'll see. Herb?
Yeah, I've been heavily involved in West Virginia in supporting the emergence of naloxone programs.
Mm-hmm.
But, you know, I get this nagging factor that keeps popping up, and that is what happens in the aftermath of an overdose reversal with naloxone. Could you talk to me about what's happening in Eastern Tennessee that you're aware of that involves approaches to contacting overdose survivors, influencing their linkages with recovery, treatment, harm reduction, and those sorts of things? You talked about the fragmented nature of this issue, and this certainly, to me, is a big gap in the continuum.
So I'm glad you brought that up. It's an area that we're struggling with as well. we're trying to figure out how do we do like a registry? What system can we put in place that will help facilitate exactly that? Because right now it's very piecemeal, it's very fragmented. We've noticed exactly the same thing, and it's something that we're trying to work through. There are some other issues related to naloxone that people are beginning to report, which is multiple uses of naloxone with the same individual, which is really troubling if you think about it. But at the same time, then you still have another chance with that person. So, or at least that person still has another chance. But my answer to your question is we're in the same boat. We're trying to figure out what to do with that exact situation. We're beginning to think about things like trying to collect follow-up information and getting all that organized. But the problem is once you disseminate the naloxone out to the user, you also have to get them engaged in your approach. And so that's that next level out you have way less control over.
If I could just follow up real quickly, because I don't want to take all the time, but your point about a Central Appalachian Collaborative is, I think that's going to be essential because there are common issues that we can definitely work out together, as well as, comparing activities and programs that have been effective in one and looking at their adaptability to the other.
That's right. It would be an opportunity also for some natural experiments, for having turned on different policies and turned, at different times. I think that may be something that we can look at. But how we get it organized, I think we need to do it with some urgency, and I think that we can find some resources to support it. Thank you. Sir?
Actually, my second year of physical therapy school here.
Oh, yeah.
And just some general idea here of this, people who are on opioids, usually on them for pain, obviously, right? So, a lot of times the cause of the pain is a movement dysfunction or some sort of problem in their movement system, that's the source of the pain. So then we're prescribing opioids to treat the symptom instead of actually treating the cause of the pain. So that's just a thought. So it would be more effective if we could kind of skip the opioids and treat the source of the pain. So an analogy would be, if there's a leak in a pipe above your room, and the pipe was leaking every day, would you rather wipe up the floor every day, mop up the floor, or truly fix the pipe? So that's just some thought.
I'm for fixing the pipe. And I'm totally with you on the physical therapy. That's true. Yes.
So you talked about there's 350 now evidence-based treatments that work at different places.
350 primary prevention programs just at the NREP side alone.
Okay, so if we have 350 things that work, why is it not working?
So a couple of things. So if you go to the National Registry of Evidence-Based Programs and Practices, it is designed for people, for a lay audience to actually consume. But people don't consume it. I can't tell you how many times I've gone to a new group to talk about this. And a lot of civic organizations are like this. They want to do the right thing. They want to help. But they want to help with the knowledge that's in the room. And what happens is, well, we just got to tell them not to do drugs. Yeah, we just got to tell them not to do drugs. And it's not always that naive, but it's often not at the level of seeking a really strong evidence-based tool. And so part of it is lack of knowledge from a well-meaning public that wants to do something about it. Part of it is, sometimes particularly with high fidelity and that is where actually have good impact that is then this. So there's a fair amount to dissemination science and implementation science. And I think that folks just don't engage with it at the level that it actually requires. And sometimes I see, and this even happens in Tennessee, we actually have a statewide program that's funded at a level of $15 million a year for coordinated school health. Okay, our coordinated school health coordinators are required to use the evidence-based model. The evidence-based model, they use the Michigan model, right, which isn't all that, I mean, it's really good for chronic disease, but not necessarily that great at maybe something like this. We actually have this enormous infrastructure in our state, and they're pushing a product that isn't necessarily going to hit this problem. It's going to hit a different problem. So there's all kinds of competing demands for resources. I think that we can begin to nudge coordinated school health back into this direction where it can be very useful for this. And I do believe that over time we're going to see, with more concerted efforts at once that are less fragmented, I think we're going to see a better outcome. But it's going to take all of the above. It's not a this or that, it's a this and that. And instead of sort of throwing up our elbows and protecting our little piece of it, it's going to have to be okay, how can we actually work together to accomplish these multiple long-range goals? But I agree with you, it is frustrating because the charts continue to increase. And people began really paying close attention to this, I think, probably two to 3 years ago.
And has anybody been using the RE-AIM evaluation format to
Yes.
look at how these things are implemented and evaluated?
So thank you for that, Dr. Nash. Our team is engaged with the RE-AIM work. There's a really cool
Right, yeah, thank you. So I was just going to, the first few slides, it seemed like you had a lot of pharmacoepidemiology that came from your prescription drug monitoring program. Can you talk about how you kind of work with them to be able to use that for research? Because not every state lets you use that for research purposes to do pharmacoepidemiology.